Swayam Prabha. Digital India. Educated India.
Good day all of you. This is Dr. Gaurav Agnihotri and today I am going to give a talk on the ischiorectal fossa. The ischiorectal fossa is actually a misnomer. It's a very difficult thing to start a class like this, but actually this terminology has been used for years and years, but now what the anatomists are feeling is that this term is actually a misnomer. So it is the ischiorectal fossa, better be called as ischioanal fossa. So it's a wedge-shaped fossa present on each side. If I put my hands like this, one hand is representing the fossa of right side and one hand is representing the fossa of left side. So it's a fat-filled space essentially. There are other structures also in it. We'll describe it in detail. So it's a fat-filled space on either side of the anus. So it better be called ischioanal fossa. So the gap which you are seeing in between my fingers of the two hands, that represents the anus. So this fat-filled space or the ischioanal fossa, instead of ischiorectal fossa if we can call it, it is very important because it allows the distension of the anus. So it has got a functionality associated with it. Whenever the anus is distended, this contracts because it contains fat on either side, and because of the contraction it allows distension of the anus. Again, a very important structure in the body is the pelvic diaphragm. Now the pelvic diaphragm is lying on top of the ischioanal fossa on each side. So the ischioanal fossa has got fat, it supports the pelvic diaphragm above, and you know pelvic diaphragm is one of the diaphragms in the body which is very important for providing support to the organs, the pelvic organs. So ischiorectal fossa has got a functionality associated with it. It represents the two wedge-shaped spaces which better be called ischioanal fossa lying on either side of the anus, and this fossa filled with fat contracts when there is distension of the anus, and this fossa is also supporting the overlying diaphragm that is formed by levator ani, that is the pelvic diaphragm. And this fossa in its lateral wall somewhere around here contains a canal. That canal is called Pudendal canal. So in the center is the anus and on either side is the ischioanal fossa, and the lateral wall contains a canal known as the Pudendal canal. Now this Pudendal canal carries the neurovascular supply of the perineum. So the fat in the fossa, it protects the Pudendal canal. So Pudendal canal is also one of the components of ischiorectal fossa or ischioanal fossa, and the presence of Pudendal canal gives it vital importance because Pudendal canal is the neurovascular supply of the perineum. So Pudendal canal is also a content of ischioanal fossa, and the main content of ischioanal fossa is fat. There are actually 6 constituents of the ischioanal fossa, but initially I just want to concentrate on the functionality of the ischioanal fossa. So I will repeat my 3 findings. Ischioanal fossa has got 3 types of functions. It supports the overlying pelvic diaphragm formed by the levator ani. It allows the distension of the anus, and it provides a cushion to the Pudendal canal lying in relation to its lateral wall. So these things the students must understand before we go into the morphological characteristics of this wedge-shaped space on either side of the anal canal. So this ischioanal fossa has got clinical implications, and those clinical implications are depicted on the monitor in the slide. So one of them is abscess. So there may be an abscess formation in the ischioanal fossa. So if an abscess is formed in the ischioanal fossa, I told you this has got fat in it. So if an abscess is formed in it, the fat is loosely arranged. So abscess contains fluid. So that fluid has got space to expand because the fat is compressible. So the swellings in this region, the abscesses in this region of the ischioanal fossa, they are not that painful. Then another applied aspect of this fossa is the fistula in ano, or the fistula in rectum, or the anorectal fistula. Sometimes what happens is that this abscess which is formed, it opens inside the anus. So on either side of the anal canal you have got two wedge-shaped spaces, and if an abscess is formed here, it may drain into the anus in relation to the anal crypts. That is what is called as the fistula in ano. So this fistula may be formed inside, or it may also be formed outside in relation to the perineum. This is shown in the slide. The one line is going inwards into the pink portion, which is the anal canal, and the other line is going outwards towards the perineum. So a fistula formation may take place in relation to the ischioanal fossa. Then if the fistula which is formed, which is coming towards the outside, if it does not heal, it may lead to formation of sinus. Another fact is that the fat in the ischioanal fossa, it may get lesser in amount, particularly in children if they have diarrhea for a long duration of time. So if this fat is not there, it has been observed that this leads to prolapse of rectum in the children. So another function which can be attributed to the ischioanal fossa is that it provides stability to the rectum, it provides support to the rectum, it allows for distension of the anal canal. At the same time, the fat in it provides the cushioning effect. It acts like a cushion for the rectum, without which the rectum tends to protrude out through the anus, what is referred to as prolapse of the rectum. So this ischioanal fossa, mind you, do not think it is a structure which has got lesser importance, because once you go through it in the textbooks, one doesn't realize the clinical aspects and the manifestations associated with the ischioanal fossa. Now another thing is that at its apex, sometimes the boundaries are not properly attached. This fossa has got a base below and an apex above. So sometimes its boundaries are not properly attached and a deficiency is left there. That is called as the hiatus of Schwalbe. We will be discussing it subsequently. Through that, the pelvic organs can herniate into this ischioanal fossa. So ischioanal hernia is also a terminology which I would like to introduce to you. So all these are the clinical manifestations of the ischioanal fossa, and keeping these manifestations in the background, I will start my lecture today, I will start my talk today, and I just made this broad outline to you to keep you interested, because this topic in the perineal region is avoided mostly by students, because it comes in the end of the last part of the book, and because the pelvic fascia, the attachments of the pelvic fascia and the perineal membrane and all, students find it difficult to comprehend initially. But once if you realize the clinical implications of this area, I am sure the students would like to go into detail regarding the morphology and the anatomy of the ischioanal fossa. So stay with me as I continue now with the slides describing the ischioanal fossa. So ischioanal or ischiorectal fossa, as is classically mentioned in the textbook, it is a wedge-shaped space. If you see the figure here in front of you in the slides, marking 1 which I have made, that is the ischioanal or ischiorectal fossa. So this green colored area marked by 1 in the figure is the ischioanal fossa. It is a wedge-shaped space situated 1 on each side of the anal canal below the pelvic diaphragm. If you see C in the figure, C depicts the levator ani. So levator ani is the pelvic diaphragm. So this one, which is the ischioanal fossa, it is filled with fat. It supports the C, that is the levator ani muscle on each side, which is forming the pelvic diaphragm. Now, a unique thing about this ischioanal fossa is that its base is directed downwards while its apex is directed upwards. So, the base is directed downwards while the apex is directed upwards. So, the base is formed by the skin. We are more concerned with the apex. You can see that pointed portion, that area which is marked by 1, it has got a pointed portion. That pointed portion, the upper margin of that is marked by D. So, it is the area where D and F meet. D and F. D represents the inferior fascia of the pelvic diaphragm, while F represents the obturator fascia in the figure. The marking E here stands for obturator internus. So, there are two important muscles in relation to the ischioanal fossa. One is the levator ani and one is the obturator internus, marked by C and E in the figure, and where the inferior fascia of pelvic diaphragm, that is D, meets with the obturator fascia, which is marked by F in the figure. So, where D and F they meet, that point is the apex of the ischiorectal fossa, and above D is lying the levator ani muscle. Now, the tendinous origin of levator ani muscle, if suppose it leaves a gap, then that gap is called the hiatus of Schwalbe, through which the hernia can take place of pelvic organs in the ischioanal fossa. So, we have described the base and the apex of the area marked by 1 in the figure, which is the ischioanal fossa. It is mostly filled with fat, though there are other contents also. We will go into detail. So, this ischioanal fossa has got dimensions, and those dimensions have been measured, and I will tell you why the measurements are important later on. The length of the ischioanal fossa comes out to be 5 centimeters approximately, that is the anterior posterior length. The width or the side to side length comes out to be 2.5 centimeters, while the depth of this fossa vertically is from 5 to 6.2 centimeters. So, why this morphometry is important, we will go into the detail subsequently. At this point of time, I do not want to touch it. So, continuing further with the boundaries of the ischioanal fossa, well, it has got anterior boundary and posterior boundary also. So, in this particular slide, we are seeing the this particular slide, we are seeing the horizontal section in relation to the ischiorectal fossa. Horizontal section in relation to the ischiorectal fossa. This is a surface view. So, in this surface view, we see the green area that represents the perineal membrane. Okay. So, anteriorly, the ischiorectal fossa is limited by the posterior border of the perineal membrane. Anteriorly, the ischiorectal fossa is limited by the posterior border of perineal membrane. So, this green structure which you see here, that is the perineal membrane. So, its posterior border forms the anterior relation of the ischiorectal fossa. If we look at the posterior boundary of the ischiorectal fossa, posteriorly the fossa reaches the lower border of gluteus maximus, and sacrotuberous ligament is also forming the posterior boundary of the ischiorectal or ischioanal fossa. Now, sacrotuberous ligament in this particular figure is marked by 1. So, that represents the sacrotuberous ligament. Marking 1 represents the sacrotuberous ligaments. So, the posterior margin of the green colored portion in the figure and 1, they are representing the anterior and posterior demarcations of the ischioanal fossa. Now, coming again to the boundaries. Now, so far we have done the base, we have done the apex, and now we are going to do the lateral and medial boundaries. If you look at the figure once again, the lateral boundary, lateral wall is vertical. So, it is like a straight line, while the medial wall is curved. So, these two where they meet, that is the apex. So, the lateral boundary of the ischiorectal fossa is like this, inferior boundary is like this, while the medial boundary is not straight, but it is curved. So, where the lateral and medial boundaries are meeting, that is the apex of the ischioanal fossa. Now the lateral wall is vertical and it is formed by two structures. One structure is the obturator internus, which is marked by E in the figure. It has got a fascia in association with it, while the medial surface of the ischial tuberosity, lateral wall is formed by obturator internus and obturator fascia. So if we come to the medial surface, which I told you is oblique, the medial surface has got a different orientation. So once again, the lateral wall is vertical and is formed by obturator internus and the obturator fascia in the upper part. In the lower part, we have got the medial surface of ischial tuberosity. So there are two structures lying in the lateral wall of the ischioanal fossa. Above is the obturator internus and below is the ischial tuberosity. So this is the coronal section in relation to the ischioanal fossa, and you are seeing the lateral wall of the ischioanal fossa. Above you find the obturator internus. My fingers, they are representing the obturator internus, while my palm is representing the ischial tuberosity. So in this figure you see that E represents the obturator internus, and that portion which is lying below it, that is the green colored portion lying below the red colored portion marked by H, that is representing the ischial tuberosity. Now we come to the medial wall. I told you the medial wall is oblique. It slopes upwards and laterally, and where the lateral and medial walls meet, that point is the apex. So the medial wall is formed by which structures? The medial wall is formed by the external anal sphincter. If you see in the figure, which is the showing you coronal section of the ischiorectal fossa, you will find that there are three red structures marked by A, B and C, small a, small b and small b. They represent the different parts of the external anal sphincter. So the deepest one is called the deep part, the middle one is called the superficial part, while the third part is called the subcutaneous part of external anal sphincter. Coming back again to the medial wall of the ischiorectal fossa. The medial wall of the ischiorectal fossa is sloped. So it is formed by the external anal sphincter and its three constituents. And in the upper part, the medial wall is formed by the levator ani muscle, what you see as the C in the figure, marked by C in the figure. So below you have got the external anal sphincter, above you have got the levator ani. So small a, small b, small c, and above you have got the big C. These are forming the curved medial wall of the ischiorectal fossa, while the lateral wall is formed by E and H, that is the obturator internus and the ischial tuberosity. And where C and E are meeting, that is the apex of ischiorectal fossa or ischioanal fossa, and it has also got a base which lies inferiorly. So if the previous section was the coronal section, this is the parasagittal section in relation to the ischiorectal fossa. And what it depicts, what this parasagittal section is essentially depicting are the recesses in relation to the ischiorectal fossa. Now see, ischiorectal fossa we say has got an apex, a base, a medial wall and a lateral wall. But the story does not end here. Some parts of it are extending beyond these limits, and that you cannot make out in the coronal section. So for that we have got the parasagittal section. And in this particular parasagittal section, if you look at 2, that shows the main part of the ischiorectal fossa. Now main part of ischiorectal fossa is the one which you saw in the coronal section, but there are some extensions of the ischiorectal fossa or the ischioanal fossa which are marked by 1 and 3 in the figure. They represent the anterior recess and the posterior recess of the ischioanal fossa. Now anterior recess and posterior recess, now anterior recess, it lies in relation to the pubis. So if I describe it, the anterior recess extends forwards above the perineal membrane, reaching almost up to the posterior surface of the body of pubis. So you see in the diagram also that in front of 1 you have got the pubic area. This anterior recess is very closely related to the prostate in males or the vagina in females. So, what is the anterior recess? It is the recess which is lying anteriorly, and it is an extension of the ischioanal fossa which is lying or oriented anteriorly. Then there is a smaller recess which is marked by 3 in the figure. So, that 3 in the figure is the posterior recess of the ischioanal fossa. As you can make out in the figure also, it is smaller than the anterior recess and it extends deep to the sacrotuberous ligament. So, there are 2 important recesses, anterior recess and posterior recess. So, if you have the ischiorectal fossa on each side and the gap between the 2 hands of mine is the anal region, then anterior recess is there and posterior recess is there. But then there is also a recess which connects the 2 ischioanal fossae behind the anal canal. So, if I join my thumbs together like this, now my thumbs are representing the horseshoe recess. So, what is the importance of this horseshoe recess is that suppose infection takes place in the left ischioanal fossa, then there is actually, and the gap between my hands is the anal region, then there is actually a possibility of infection to spread from one side to the other through the communication between my thumbs, which is representing the horseshoe recess of the ischioanal fossa. So, behind the anus, the 2 ischiorectal fossa or the 2 ischioanal fossa are connected to each other by a recess that is called the horseshoe recess, and this recess provides an anatomical conduit via which infection from one side can spread to the other side. I hope this concept is clear to you, because reading the text does not clarify this concept. So, this is more a job of the teacher to elaborate on these subjects. Now, spaces and canals of the fossa. Now, here what I want to show you is, what I want to talk to you about in this coronal section pertaining to the ischioanal fossa is the facial relations and how one is separated from 2 in the figure. So, 1 is the ischioanal fossa while 2 is the perianal space. And what is the difference between the infections of ischioanal space and perianal space? So, that is what I want to concentrate on. So, perianal space is represented by 2 in the figure. We had previously concentrated on 1, which was the ischioanal space. Now, this perianal space has got a perianal fascia. This perianal fascia is represented by L in the figure. So, this is separating the ischioanal fossa from the perianal space. L is separating the ischioanal fossa from the perianal space, and this L is representing the perianal fascia. So, what is it? It is a septum that passes laterally from lower end of longitudinal coat of anal canal. Now, where is the longitudinal coat of anal canal? For that, I will take your attention to this section of the ischiorectal fossa once again. If you see, in relation to the rectum, there are 2 markings A and B. A is the inner coat, B is the outer coat. Inner coat is the circular coat, outer coat is the longitudinal coat. So, that longitudinal coat comes down and this perianal fascia passes laterally from the lower end of the longitudinal coat. You can easily make it out in the figure. The circular coat is forming I. I is the internal sphincter, while external sphincter has got 3 parts lying outside the longitudinal coat, and you can see at the lower end of the longitudinal coat extending from medial to lateral side is L, which represents the perianal fascia. So, this perianal fascia extends medially from white line of Hilton. White line of Hilton is marked by K in the figure. To Pudendal canal laterally, Pudendal canal is marked by 3 in the figure. So, Pudendal canal is the neurovascular supply to the perineum. So, from white line of Hilton to Pudendal canal is L. L is the perianal fascia, and below L is lying the perianal space. So, these facial extensions, they are not so complicated if they are comprehended in the right manner. So, it separates a shallow subcutaneous, this L separates a shallow subcutaneous perianal space from the deep ischioanal space. Now, there is difference. I want you to concentrate here that there is difference between the arrangement of fat in 1 and 2. One is the ischioanal fossa. There the fat is loosely packed. The septa around the fat are incomplete. If suppose this is one locule, if my hand is now representing one locule, locule means an area of fat. Now, this locule, the boundary is not complete, fat is loosely packed and it is large in size. This is the scenario in case of ischioanal fossa. While in perianal fossa, perineal space, what happens is the locules are smaller in size, very small. The fat is tightly packed. So, this small area between my fingers of both hands, the locule is small, fat is tightly packed and the walls are complete. So, this is the scenario in case of perineal space. Now, how will the infection differ in the two spaces? Suppose an abscess is formed in the ischioanal fossa and an abscess is formed in the perineal space. If the abscess is formed in the ischioanal fossa, the locules have got fat loosely packed. So, there is space for fluid to accumulate. The locules are not complete. So, when tension is exerted onto the locules, they will expand. So, less pain will be felt in case of abscesses in the ischioanal fossa vis-a-vis the abscesses in the perineal space. Because the perineal space, the fat is tightly packed into small loculi bounded by complete septa. So, there is difference in the kind of abscess formed in the ischioanal fossa and the perineal space. Perineal space abscesses are very painful, ischioanal fossa spaces, they are relatively painless. So, I read from the slide, fat in this space is tightly arranged. We are talking about perineal space in small loculi formed by complete septa. So, infections of this space are very painful due to tension caused by the swelling. Now, we come to the ischioanal space. Once again, ischioanal space infections are very painful. So, perianal fascia, we have seen that it separates the ischioanal fossa from the perianal space, and infections in the perianal space, they are very painful, while infections in the ischioanal fossa are relatively painless. Now, we come to the lunate fascia. Now, what is the lunate fascia? Lunate fascia arches over the ischioanal fat. So, you see in the figure, the lunate fascia is marked by a capital G. So, that is the lunate fascia. It begins laterally at the Pudendal canal and merges medially with the fascia covering the deep part of external anal sphincter. So, if you see on the lateral aspect, in the lateral aspect of the ischioanal fossa is the Pudendal canal. So, from there is this fascia, lunate fascia is going up and then it is passing up and merges medially with the fascia covering the deep part of the external anal sphincter. So, this is marked by G in the figure. So, this is called the lunate fascia, and this G in the figure is separating the 4 from 1. 4 represents the suprategmental space, while 1 represents the tegmental space, or 1 represents the ischioanal fossa. So, this lunate fascia is dividing the ischioanal fossa into a suprategmental space and a tegmental space. So, this means that it is separating 4 from 1. This ischioanal fossa has got 2 components now, which we can make out. One is lying below the lunate fascia and one is lying above the lunate fascia. The part lying below the lunate fascia is the tegmental part of the ischioanal fossa, while the part lying above the lunate fascia is the suprategmental part of the ischioanal fossa. So far in my class, I have refrained from expressing 4 as a part of the ischioanal fossa because I wanted to describe it here only, that it's a small part, the suprategmental part, which is also a component of ischioanal fossa, lying in relation to the apex of the ischioanal fossa. So now we come to the neurovascular bundle lying in the ischioanal fossa, that is called the pudendal canal. I mentioned it lies in the lateral wall of the ischioanal fossa. If you comprehend that my two hands are representing the ischioanal fossa of both the sides with the anal canal in between, then in the lateral wall of the ischioanal fossa lies the pudendal canal. So what is the pudendal canal? Pudendal canal is a fascial canal in the lateral wall of ischioanal fossa, enclosing the pudendal nerve and internal pudendal vessels. So if you see the figure here, 1 represents the ischial spine, 2 represents the lesser sciatic notch, then 4 will represent the pudendal canal. Now this pudendal canal is lying in relation to the hip bone as seen in the figure, and this is lying on the lateral aspect of the ischioanal fossa. Fascia of this canal is fused with the lower part of obturator fascia laterally, with lunate fascia above, with perineal fascia medially, and with falciform process of sacrotuberous ligament below. So 3 here in the diagram represents the ischial tuberosity, while 5 here in the diagram represents the perineal membrane. Now we come to the contents of the ischioanal fossa. So far we have mentioned 2 contents, one is fat and other content we have mentioned is the pudendal canal. So the most important component is the ischiorectal pad of fat. Now the second important component is the inferior rectal nerves and vessels. So inferior rectal vessels are represented by 6 in the figure, while inferior rectal nerves are represented by 4 in the figure. So blue and red represent the pudendal artery and vein, while yellow represents the pudendal nerve lying in the pudendal canal. Now inferior rectal nerves and vessels, they are an important component of the pudendal canal. They pass through the fossa from lateral to medial side. They arch upwards above the fat to supply the mucous membrane, external sphincter and skin around the anus. So it must be very clear to the students. Students should be able to comprehend that what area this inferior rectal nerves and vessels are supplying. They are supplying the skin around the anus, external anal sphincter, and they are supplying the mucous membrane in relation. So this is the area supplied by the inferior rectal nerves and vessels. Then the third content of the ischioanal fossa is the pudendal canal. This canal lies along the lateral wall of the fossa. So first we come to the pudendal nerve. Pudendal nerve has got root value S234. In the posterior part of the canal, pudendal nerve gives off the inferior rectal nerve. We see 4 coming out of the B. B is the pudendal nerve and we see 4 coming out of B. So this is the inferior rectal nerve which gives, and then it soon divides into a larger perineal nerve and a smaller dorsal nerve of penis. So then we see further as this B goes out, it gives 4, then a part which goes down, that is 2 in the figure. So the part which is going down is the perineal nerve, while the part which is lying up, that is the dorsal nerve of the penis. So this pudendal nerve is traversing through the pudendal canal. Then we have the internal pudendal artery. This also gives the inferior rectal artery in the posterior part of the canal, marked by 6. In the anterior part of the canal, the artery divides into perineal artery and an artery of penis. Vein accompanies the artery. So the veins are accompanying the arteries. Then the other content, the fourth content of the ischioanal space is the posterior scrotal or posterior labial nerves and vessels. So posterior scrotal or posterior labial nerves and vessels, they are also present. They cross the anterolateral part of the fossa and enter the urogenital triangle. So another content of the ischioanal fossa is the perineal branch of the fourth sacral nerve. It enters posterior angle of fossa and runs over levator ani to external anal sphincter. Another content of the ischioanal fossa is the perforating cutaneous branch of S2, S3. They appear at lower border of gluteus maximus in the posterior part of the fossa. So all these are components of the ischioanal fossa. perineal branch of fourth sacral nerve, perforating cutaneous branches of nerves S2, S3, pudendal canal, the fat and the inferior rectal nerve. Now we come to the clinical aspects once again in relation to the ischioanal fossa. As I mentioned before, the two ischioanal fossa, they allow distension of rectum and anal canal during passage of fecal matter. Both perianal and ischioanal spaces are common site of abscesses. Now in this particular figure, we can see an abscess in the ischioanal region, ischioanal fossa, marked by A. And we also see an abscess in the ischioanal region, and we also see B. B represents the fistula which is passing out into the perineum, while we also see a fistula which is entering the anal canal medially. So both perianal and ischioanal spaces are common sites of abscesses. We have already discussed this before. The perianal space abscesses are very painful, while in the ischioanal space the abscesses are not so painful, while fistula can take place due to formation of these abscesses. Sometimes an abscess may burst into the anal canal. As you can see in the figure, on the medial aspect, the abscess is bursting into the anal canal, or it may happen in the rectum also. And as you can see in the figure, B represents the abscess bursting onto the surface of the perineum externally. So this figure is showing you the abscess marked by A and the fistula, one which is unmarked on the medial side, that is the internal fistula, and the one which is marked as B is the external fistula, which is opening out into the perineum externally. So in this way, an ischioanal type of anorectal fistula or fistula in ano may be produced. The most common site of internal opening is in the floor of one of the anal crypts. This is important and I stress on it again. The most common site of internal opening is in the floor of one of the anal crypts. If the abscess bursts only externally, suppose we look at scenario B. So if there is a abscess which bursts externally and healing does not take place, then what may happen? An external sinus may be produced. And as I mentioned before, through a horseshoe recess lying behind the anus, unilateral abscess may become bilateral. Then other applied aspects in relation to the ischioanal fossa. Well, the ischioanal fat acts as a cushion-like support to rectum and anal canal. Loss of this fat in debilitating diseases like diarrhea in children may result in prolapse of the rectum. So it is a very important cushion, the fat in the ischioanal fossa. It provides support to the pelvic diaphragm, it provides support to the rectum. Without this, there are chances of prolapse, particularly in children. Then we come to the hiatus of Schwalbe and the concept of the ischioanal hernia. As I told you before, in relation to the apex of the ischioanal fossa, sometimes there is a hiatus of Schwalbe. So hiatus of Schwalbe is lying in relation to the apex. So the occasional gap between the tendinous origin of levator ani and obturator fascia is known as hiatus of Schwalbe. So what is the importance of hiatus of Schwalbe? Pelvic organs may herniate through this gap into the ischioanal fossa, resulting in an ischioanal hernia. So pelvic organs may herniate into the ischioanal fossa, what is referred to as ischioanal hernia. Now we come to the concept of the pudendal nerve block. Pudendal nerve is supplying sensory branches to the lower part of vagina through inferior rectal and posterior labial branches. So this is a very important feature actually, pudendal nerve block. With the revolution in therapeutic measures, you know, this pudendal nerve block saves the patient from general anesthesia. So what happens here is local anesthesia is infiltrated into the pudendal canal in relation to the pudendal nerve, and due to local anesthesia, patient recovers also early and the complications are also less. So what is done in pudendal nerve block is there are two ways to do it. One way to do is that the needle is passed per vaginum by feeling the ischial spine. The ischial spine is felt, and in relation to that the injection is given of the local anesthetic. So the posterior labial branch of the pudendal nerve is supplying this lower part of the vagina, so along with the inferior rectal nerve. So both of them are anesthetized by this injection which is given by feeling the ischial spine through the vagina. So this is the transvaginal approach. The other approach is the external approach, wherein the patient is made to lie in the prone position, the ischial tuberosity is felt, and just medial to the ischial tuberosity, if my thumb is representing the ischial tuberosity, just medial to the ischial tuberosity, the local anesthetic is injected. But one has to make sure that the needle passes at least 2.5 centimeter deep. When I mentioned the boundaries of the, when I mentioned the dimensions of the ischioanal fossa, this is the importance of the dimensions, that when the needle is inserted, it should pass at least 2.5 centimeter deep into the buttock medial to the ischial tuberosity, so that the pudendal nerve is properly anesthetized. So local anesthesia is a big revolution vis-a-vis the general anesthesia, which saves the patient because the time of recovery is less, and the patient can cooperate with the procedure. So in operations of the lower part of the vagina, pudendal nerve block is frequently done, and this figure here in the presentation is showing G. G is the area where the local anesthetic is injected, so that it takes effect, and the lower part of vagina, which is supplied by the inferior rectal and the posterior labial nerves, that is properly anesthetized. So in today's lecture, I have concentrated on the clinical aspects related to the ischioanal canal, and all these clinical aspects need to be comprehended, understood, so that proper and effective treatment can take place. I thank you for your patience and cooperation. Till the next time we meet, this is Dr. Gaurav Agnihotri signing off. Bye bye, thanks, regards and namaste.